So this is a very dry topic, but we're going to try to make it fun, and I'm hoping the questions will make it more fun than what I can do with it. I'm on, these are my disclosures. Yes, I do have a lot of consultancies. And I'm talking, everything I'm trying to speak about this morning is pretty much off-label. You're not going to find any of the dosing recommendations I'm going to talk about in a package insert. And that's oftentimes one of the challenges is when consumers try to get things reimbursed, it's because it's not an approved indication. Okay, learning objectives, we're going to talk about how our acid suppression could influence overgrowth, some of our treatment regimens, and some of the limitations associated with these therapies. Okay, bacterial overgrowth, we oftentimes refer to it as SIBO. It's not the same as the SIBO syndrome, and typically an acceptable definition is when they see more than 10 to the 5th colony-forming units of bacteria per milliliter of fluid that they aspirate from the small intestine when they do the diagnosis. When you have the syndrome itself, you see an increased number of your colonic bacteria. As a result of this situation, you do see nutrient malabsorption, and that's what we're really concerned about. It's because the bacteria itself or its the metabolism, byproducts of the bacteria result in D-lactic acidosis, elevations in serum ammonia. We see ethanol and autointoxication. This isn't a new concept. It was actually first described many years ago when back in the day when people used to get surgical procedures for management of ulcers. And they had a procedure called the Billroth procedure. And when this procedure, when they created blind loops of bowel, and as a result, these little pockets of bowel would dilate up and bacteria would fester in there. So these patients developed overgrowth. And it's a condition that has many different causes, so that's why there's many different approaches. It's an infectious process, there's inflammation involved. Patients oftentimes have a surgical procedure that results in them becoming predisposed to overgrowth. There's dysmotility components. Could be due to different medications, such as those that suppress gastric acid production, like the proton pump inhibitors, like Prilosec, or the H2 blockers, like ranitidine and famotidine. And different patient populations tend to be at greater risk for getting this condition, those with cirrhosis, non-alcoholic steatohepatitis, Crohn's, irritable bowel, those with intestinal failure, pancreatic insufficiency. So it's not just one group of symptoms, one cause, it's many different factors. But the symptoms are all the same. You feel bloated, you fill up quicker, you don't feel like eating, you get crampy, you get steatorrhea, you feel lousy. So what is normal? This shows you just graphically that we're pretty much a mass of bacteria, unfortunately, from head to toe. And the amount of the bacteria distribution varies dramatically from your mouth to your colon. And and the flora changes as we go up and down our GI tract. And typically the intestinal flora mostly resemble our GI epithelial cells. And that regulates how we absorb nutrients, how we conjugate bile acids, how we metabolize and absorb various vitamins, and how our gut stays intact so bacteria can't get into our bloodstream. And that's the norm. So when we disrupt the norm, that's when we start having trouble. And this is another graphic way of showing you how much bacteria we have in different parts of the body, and that's how the team makes that diagnosis. Do you have overgrowth? As we start with our mouth, we have a certain percentage of bacteria, but when we hit our stomach, the gastric pH knocks it down to almost 0. But as we traverse further down our GI tract, the number of bacteria increase gradually until we have the most bacteria in our cecum. So, I mean, these slides will be available online if you really want to know the down and dirty numbers, but just trust me, it gets from top to bottom, it gets higher and higher. But when you have overgrowth, you have this competition for nutrients, you and the bacteria. And we want to make sure you win, not the bacteria. As a result, you have an increased amount of unabsorbed substances because of this, and this results in damage to your mucosa. And as a result, you get steatorrhea, you get fat malabsorption because you have increased bile acid deconjugation occurs. And this all leads to the vitamin deficiencies that you're going to be evaluated for and have to supplement. And the complications, the reason we care so much about this and why we're talking about it this morning is because of the complications. You're increased risk for malnutrition. You don't grow well. You could have anorexia. You don't feel like eating. You can get that bacterial translocation where you get the gut bacteria will translate through that leaky gut into your bloodstream and increase the risk of a bloodstream infection. Your bowel can be inflamed, just friable. It's oftentimes, makes it difficult for you to come off TPN because you don't feel like eating enterally, so you have to stay on the PN to maintain your weight. Other things you can have happen when you have overgrowth is you can get neurologic complications like D-lactic acidosis. You can get elevations in your ammonia levels. You can actually get ethanol and auto-intoxication. So you can get a buzz without the pleasure of having some good wine, which is too bad. And this afternoon there are several roundtables we're going to have with my colleague, Craig Peterson, who's a dietitian, and we'll focus on the D-lactic acidosis, but just to briefly touch on it, it's a form of encephalopathy. You see mental status changes. And it's because you have an overgrowth or overabundance of bacteria in your small bowel, and it malabsorbs your carbohydrates in your colon instead of the small intestine. And as a result, you start seeing all these neurologic complications. You start acting, slurred speech, you have poor balance. You might just be altered mental status. You may not all be there. And as a result, it's usually a way, when we start seeing these neurologic symptoms, oftentimes we may see elevation in your D-lactate levels. And one thing we've noticed as we started evaluating this at our program is that people would look at lactic acid levels instead of D-lactate. And that's often a cause of delay in making identification because they're not the same. You need to make sure your team looks for a D-lactate level. There is mucosal damage associated with bacterial overgrowth as a reason because it destroys the integrity of your intestinal epithelium. As a result, there's a whole inflammatory cascade that results. And because your gut becomes leaky, bacteria can move across from your GI tract into your bloodstream, and it does impair your immune function. You start having a whole cascade of symptoms. So how do we diagnose it? There's many different approaches to how this condition does get diagnosed. Ideally, when you have an endoscopy, for example, they might look at the fluid and do a culture, like jejunal or duodenal contents. We can do breath tests. We don't see them done as much as at my place as we used to. And lastly, the most common thing I see in practice is oftentimes our team will try a course of antibiotics, see how you do, and if you get better, they call it a day until they rule out otherwise. The gold standard, especially if you read the textbooks and review articles on this condition, is the jejunal aspirate cultures. And what that is like they're going to culture the fluid that's in your jejunum and see if it exceeds the normal threshold. That we know there's going to be bacteria in your gut, but if it's greater than 10 to the fifth, they're going to say you have an overgrowth situation. Then we're going to culture and identify what exactly is in there for organisms, because maybe you have the wrong bugs in your GI tract. And it's typically more reliable than the duodenal aspirate cultures. But if you have a lot of resections, your anatomy may be different, so you may have to just culture what's there, whatever bowel you have there. Oftentimes, many of our patients get duodenal aspirate cultures just because there's not that much jejunum left. Other things we do is breath tests, and the rationale is bacteria, when they eat carbohydrates, they ferment, and you end up exhaling hydrogen. So they might want to look at that. However, it's not a perfect test. If you have any kind of dysmotility, it alters your results. If your transit time's different, if you have a different pH in your colon, it does affect how the results behave. The most common one is called the glucose breath test, and they usually do several of these. They just don't do one test and make a diagnosis. They want to see the trend. And typically, they're going to give you at least 50 grams of a glucose solution or a powder, and then they're going to take some breath samples afterwards. Again, if you have cirrhosis, you may not get good findings. You can also have false positives if your transit time is too quick. There's also the D-xylose test, which involves a radioactive isotope that can be used. Again, there's plus minuses using that. and we can't use that in children or pregnant women because it has radioaction stuff. Other tests that have been used include the urine endocrine test, and that's a byproduct of tryptophan, which is that amino acid. Typically, again, just like the other tests, it's not practical in patients who have rapid transit times, and it hasn't been validated against that gold standard of the jejunal aspirate culture. The most common thing is empiric antibiotic therapy. That means we don't know exactly what we're treating, but we know what the typical bugs are, so we're going to give you what most people respond to, and if you do respond like everybody else, they may do a diagnosis that way, especially if you start feeling better. Okay, how do we treat this? Again, as I said before, there's a whole bunch of different causes for this condition, so as a result, there's many different approaches. One is to treat, obviously, the underlying cause, if we can do that. We can do some dietary manipulation. We can give antibiotics. We can do probiotics, prebiotics, symbiotics. We can do motility medications. We can do bowel flushes. And we can do some things just simply by avoiding some medications and different diets. We may prevent these symptoms. The one thing I always tell my students and people in my practice and clinic is look at the med list, because maybe we have bad players and they may predispose you to have situations where it increases the risk of overgrowth. So, looking for drugs that cause differences in your motility. If you can switch them, great. If we don't need to use different acid blockers, and that might be an option. But again, think about ways we can avoid putting you on more medications by taking away or switching bad medications that cause this condition. The dietary manipulations, I'm not going to go into great detail. Craig can do that during the roundtables when you have specific questions. But that is the common way to approach this. It's one of the simplest approaches, because you want to provide the diet of nutrients that are readily absorbable, and you want to give the bacteria less food to eat. You want to not give them their favorites. You want to give carbohydrates that are not absorbed. You want to decrease the non-absorbable carbohydrate calories. You want to go to a high-fat diet, less carbs. And if you're an adult, a lot of adults have lactase deficiency, so you want to maybe consider a lactose-free diet. But sometimes just doing dietary manipulations may do the trick with your symptoms. Other things we got to worry about when you do have overgrowth, there are increased risks for nutrient deficiencies, in particular calcium and magnesium deficiencies, as well as iron, B12, and the fat-soluble vitamins. So you should be expecting to be maybe supplementing, additional monitoring may be required. So often we may pick up overgrowth as a result of detecting a deficiency in your panel, or vice versa. So sometimes you're not that symptomatic, but because you had a deficiency, we do further workup and we find out you do have overgrowth. So let's talk about the antibiotics. The whole idea of the antibiotics is not to treat an active infection, but to minimize the symptoms of overgrowth. Typically, we start those when your bowel's starting to dilate up or your transit time is very slow. So we're trying to manage the other complications we see with overgrowth, such as the malabsorption, the flatulence, the diarrhea, and if you had that lactic acidosis, maybe the neurologic symptoms. It's often used to decrease the bacterial translocation with the hopes of decreasing the risk of bloodstream infection. That's one of the other theoretical benefits. But the whole goal is to treat the symptoms. We're not really trying to wipe out all the bacteria. That's not the goal. And how do we pick these antibiotics? Well, a lot of it, again, is directed towards symptom relief. We want to make sure it treats anaerobes, because that's the predominant bad player in this situation. We know it's a temporary effect. You're not going to be on these chronically for forever. It's going to be over a different rotation of different antibiotics. We like to minimize the chances of having opportunistic infections, so we try to limit the spectrum of coverage towards the bad players. And that's why we like those cultures, so we know what we're dealing with. The way we do it is we usually give it over a cycle where we have you on a particular antibiotic for like 7 to 14 days. Then we give you a period of days off from that regimen. Sometimes you're in a combination of antibiotics. Sometimes it's just one agent and you're on and off it over a cycled schedule. The dosing is not the same as what you'd use to treat an active infection. It's usually half the therapeutic dose. And the one that you're probably most familiar with is flagyl metronidazole. And metronidazole is a metronidazole antibiotic. It has some nasty side effects sometimes. I mean, the one you might know the best is that it makes a very metallic-y taste, and it tastes like you're eating aluminum. You can also have neuropathy. Some patients have gone on to develop neuropathies from this, so you have to be careful. The other one you might also be aware of is the disulfiram reaction, where you can get severe nausea and vomiting if you ingest alcohol with it. And that includes not just the glass of wine, it also could be the alcohol in your medications. It doesn't happen to everybody. It's around 25% of the people are predisposed to that complication, but most people don't want you to figure it out if you're part of the 25%, so we try to avoid using alcohol in general when you're on flagyl. Other things we worry about is it also has a risk of increasing your risk of QT prolongation, which means if you're on medications that also have that propensity, you might have an increased risk of arrhythmias. So some people are very careful of screening the medications that you're on. If you add flagyl and you're on these other medications like erythromycin, cisapride, they may want to steer clear of it. Again, it's risk to benefit. Other agents that we've used Alinea, which is also very similar to metronidazole, rifaximin. That's a new one that people are starting to see used more commonly now. It's a non-absorbable form of rifampin. The problem with rifaximin is it's very, very expensive. Its improved indication was mostly for travelers' diarrhea, as well as decreasing ammonia levels with patients with encephalopathy. Very hard to get approved, I'll tell you that too. We've had a lot of difficulty getting our patients approved for this agent without going through a lot of appeals. Other things we've used, amoxicillin clavulanic acid is augmentin. You probably know about that when you've had earaches. Sometimes we use augmentin for that. It has, in addition to being an antibiotic, it does have prokinetic properties. It does affect motility. Some people will actually use it as a prokinetic agent, not as an antibiotic. The problem with augmentin is it does increase your risk of drug resistance, and we don't want that to happen. You can get diarrhea because it's a prokinetic. That's why a lot of people don't like to use it. And the dose is there if you want to share it with the team. There's a whole bunch of other antibiotics we often use for this situation, again, based on what we learned from those jejunal aspirate cultures, duodenal aspirate cultures, and I'm just listing them there before you, such as neomycin, doxycycline. Tend not to use tetracyclines for this. Bactrim, trimethoprim sulfamethoxazole. The one you might not be used to seeing is gentamicin given orally. Again, gentamicin we typically is an intravenous medication. It's not absorbed when you put it down the GI tract. The whole idea is a local therapy, which makes it more of a challenge when you're trying to get it from your local pharmacy, because most CVSs are not going to have gentamicin vials in stock, but they'd have to special order it. Some payers are questioning. They think it's a mistake when you're saying to give gentamicin down your feeding tube, but it does work for this indication. So again, there's a lot of different antibiotics depending on what's exactly growing in your GI tract. There's also a process called the selective decontamination, which again is the hope is to decrease the incidence of a bloodstream infection. You're pretty much targeting your gram-negative aerobic bacteria. And that's one of the rationales for using ciprofloxacin for that indication. This is just, I'm going to have this at the round table. This is one of the tables we have at Children's that we've come up with over the years. Very little research is done in this area, so it's what we learned from people's practices, case reports, et cetera, and we just assembled it as a tool for our team to use as a guide. And like I said, I have copies of that I can share if anybody wants to stop by the round table. There are several studies that have been out there trying to systematically look at the evidence of different therapies, comparing different therapies against the gold standard of metronidazole or flagyl. This one that came out several years ago compared flagyl to rifaximin, the very expensive drug that I just mentioned. And they were just seeing which was better. They looked at patients who got either rifaximin first, then switched to flagyl as part of their cocktail, or if they went from rifaximin and stayed on another cycle of rifaximin, or they just did the pure classic cycle flagyl. And when they looked at the results from this study, they saw that the patients who got the flagyl tended to have better symptom scores as well as response rates in comparison to rifaximin. So even despite the higher cost, you think more money usually is better. Oftentimes, good old flagyl does better than the rifaximin. And again, this is just telling symptom scores. And again, the one that they're mostly concerned about is bloating. That's the one that they really saw a dramatic difference, is they had decreased bloating with both agents. But otherwise, they saw no difference. Another study that came out a couple of years ago was flagyl versus ciprofloxacin. That's the one a lot of people like to try using now as well. Because again, a lot of people just don't want to deal with all the different, the ethanol interactions and the metallic taste. They try other agents. And this one looked at comparing flagyl and cipro. And what they noticed was in this one, that they noticed at the breath test, all the cipro patients had improvement. They all normalized in comparison to the flagyl. But when they looked at symptom scores and all the other factors, there was no difference. So again, if you can respond better on flagyl and you tolerate flagyl better, there's no harm on staying on flagyl. Other people have also done antimicrobial cocktails. These typically involve non-absorbable antibiotics. If you're listed for a bowel transplant, a lot of times the teams will actually start you on these cocktails when you're in that stage to decontaminate your gut. And what it does is it uses non-absorbable antibiotics to hope that it doesn't infect your organ systems. And that's the rationale by giving like colistin, tobramycin, another injectable antibiotic given enterally, and nystatin, the antifungal. Sometimes they'll use amphotericin, the injectable form going down the tube orally. Another approach, rather than giving hardcore antibiotics, is going to probiotics. And these are like the healthy bacteria. You're going to repopulate your gut with the better bacteria. And the thought is it's less toxic than antibiotics, less side effects. This is very old school. I mean, this has been used for centuries. As part of the rationale with eating different yogurts that have bacteria still in them. In the intestinal failure population is less experience, and that's because there was some case reports that came out in the literature that patients with central venous catheters started having infections involved in these organisms. So there was some centers actually say if you have a catheter in place, a CVL, you can't have a probiotic because you might contaminate the line, you might get a bloodstream infection. Examples of this would be like the Lactobacillus acidophilus, Lactobacillus bulgaris, Saccharomyces boulardii. So I mean, these are the ones you typically are going to see, like your Culturelles, Lactinex. Prebiotics are actually you're going to feed the bacteria. This is the stuff to increase the growth of the healthy bacteria. And this is non-digestible fermentable food, but you're actually helping that bacteria to grow the good stuff. You want the bifidobacteria, the lactobacillus. You're trying to help it grow. These prebiotics are not absorbed by the intestine, and they're fermented by your colonic bacteria. And those are the oligosaccharides, the inulins, and the fructooligosaccharides. So again, this is not a bacteria. This is the food to the bacteria. Now there's a whole other situation called symbiotics, where you're actually given both the food as well as the good bacteria together. So you get more bang for your buck, because when they're given together, you get what's called a synergistic response. So you get an enhanced response than given one or the other by itself. What you're doing is the probiotic bacteria is going to colonize your GI tract, and the prebiotic is going to stimulate their growth. So you help them both. And typically you can get even more enhanced relief is if you give it with the antibiotics. So it's even better when you give it with a triple threat therapy, so to speak. Combination, most of the time the prebiotics you can't buy by itself. Usually you're buying it in combination with the probiotic. You can see bifidobacter with fructooligosaccharides, they call it FOS. There's inulins with lactobacillus. But again, there's a lot of combination products out there, and that's the rationale. Now there's also, if you have a dilated bowel, or you have sluggish bowel, they might want to use a prokinetic or dysmotility agent. And these are the drugs. Okay, sorry. I have to do what the boss says. All right. Again, the different things like amoxicillin, the antibiotics, the ones you haven't heard about is Reglan, metoclopramide, cisapride, tigecerod. Erythromycin, typically we think of as an antibiotic. The reason we get nauseous is because it's a motility agent. We give very low doses, and we typically give it every day. But because you get this situation called tachyphylaxis, we may give you drug holidays. So you might be on it 3 out of 4 weeks a month. Metoclopramide or Reglan, again, is another agent that's a prokinetic, but it crosses your blood-brain barrier in your brain, so it causes side effects. So oftentimes people don't like to use this one anymore because it has a lot of dystonic reactions, but it still could be used. Cisapride is a great drug. Unfortunately, it has some nasty cardiac side effects. Only specialized prescribers can use it. Not every doctor is allowed to prescribe it. You have to go through a special program. You have to be restricted on your medications, but it does work well as a prokinetic agent. This is just the information. Again, lots of drug interactions, so you're given a book when you're prescribed cisapride of what to avoid. Another one similar to cisapride is Zelnorm, which also is a very good agent against IBS and the constipation perspective. Again, limited prescribers and only available through specialized programs. Bowel flushes is another thing you can consider. And it's a mechanical process. You're just physically flushing your body out of the bad bacteria. You can do it from above or below. If you do it from above, you got to take Miralax or mag citrate and just try to increase your stooling to get rid of the bad bugs. Some people actually do a good old saline colonic irrigation too to remove the bad bugs from below. Another thing you can do is avoidance strategy. Avoid excessive acid suppression, because when you block your acid production, those bad bacteria can overtake your GI tract. And our parents notice that. Their kids have more bloating when they're getting a lot of acid blockade. Mostly seen when you take a lot of proton pump inhibitors, because they're more potent, like the protonics and the Prilosec are more stronger when blocking acid production versus ranitidine or Zantac. So they've seen that. So again, if we can drop the acid production. Lastly, we got to think about the steroids. Sometimes because of the inflammation, you might have to go on a steroid for short-term use, like oral budesonide. It's another thought. Surgery's been used in our patients with really refractive overgrowth situations, especially with the neurologic complications. And by tapering the bowel, you decrease the dilation. That will also help decrease the bacterial population. So that's another option. So the key points is it's a situation where you have a lot of bad bacteria colonizing your GI tract. The management is either dietary, medications, but treating the underlying cause. If you're getting a lot of acid blockade and you don't need all that block, maybe reducing that's an option. You can also alter your diet to decrease what the bugs like. Recurrence is common. Don't expect one course of therapy to do the trick. With that, I'm going to close for now because I know we have several roundtables this afternoon, so you can get a lot more time and more in depth at that point. And we'll take questions now until then. Thank you. Sorry.
That's okay. You did a good job. I just want to make one point, and that is that if a parent has got a child on a tube feed and they think that this is causing a change in their mental status, it's a very legitimate thing to take the child as fast as you can and ask for a measurement of the D-lactic acidosis. Now, that is not done in most hospitals. In fact, the only place that I know it's done is in the Mayo Clinic. So you must have on your script, which your doctor provides you, because you're going to do it suddenly, test for D-lactic acidosis, not for L-lactic acidosis. We're not interested in that. And the second thing you can get to confirm that it's a serious acidosis is the bicarbonate level. Now, one of the questions I wanted to ask, and so I'll take the privilege of being the chairperson, which of the tube feeds, Kathleen, would you think get the closest to this terrific conundrum of trying to provide substrate, trying to clear certain bacteria? So if you talking to parents, the child is on a tube feed, what are you going to recommend?
Ooh, well, I'm not going to even. Luckily, I'm part of a multidisciplinary team, and I would defer.
Sidestepping, Kathleen.
I am going to sidestep because that is not my area of expertise. But I mean, most of my kids are on Neocate and Elecare. That's the problem with my situation. We don't have many patients who are on complex regular house diet or like liquid hope type diets. They're on these elemental formulas. So I mean, that's where we have to. I defer to the dietitians if they want to change from that, because that's the bulk of what I see. So that's why I'm not going to answer with a specific situation and defer to Craig this afternoon, because he might see different kinds of patients than I see. That was Craig.
Well, well, I think theoretically, Craig, Kathleen, at least you might look for a tube feed that uses fructans. Because that clearly is one of, you might use for a tube feed that emphasizes fructans, because that will tend to suppress this situation. So I think there are some options there that one can consider. Anyway, who else has run into this and perhaps had to deal with it and had some of the frustration from it? We'd like to hear from you. Carol.
Actually cause the FOS and inulin actually cause more symptoms. So the gas, the bloating. So much of the time when I have somebody with the bacterial overgrowth, I'm trying to limit those in their diet, and when you look at a tube feeding, it's very hard to find them. If they're fiber supplemented, they do have a lot of the prebiotics. So to me, that even though they're prebiotics, during that time when these people are malabsorbing and that's going to the colon even as much as they have, it can be a real challenge with the symptoms. So it varies.
Hi.
Hi, I was on that same vein. I have been on Peptamen 1.5 for a long time, and it's been working great for me, but I've had historical challenges with bacterial overgrowth, and it's finally under control, and I'm considering trying Peptamen 1.5 plus prebio. And so I'm nervous because I don't want to go down that road again. It was like 2 years of constant, like I'd be on Xifaxan, I tried Flagyl, I tried the combination, I had and I just, what do you think? Do you think it's worth the shot to try the prebio?
Right now, you're in good shape?
Well, not great
From a
shape,
symptom
but
perspective?
as far as SIBO goes, I feel like it's been a couple months that I haven't had those issues, but I don't know. I'm trying to figure out a way to.
Based on what I've just heard from the others here, I would say stay the course with what you're using, because they're not.
Yeah, I mean, but this is only like 3 or 4 months after like 2 years of a constant every couple months. So I'm just, I just talked to the dietitian here from the company that I work with, and we were going to try it, but I said to her, I don't want to go back to that, but if I could avoid it.
Yeah, this hearing.
Okay.
You know what? You need fiber, at some point, and so there is a good fiber, PHGG and guar gum, partially hydrolyzed guar gum. It does come all alone from one of the companies, and we'll have to figure out which one. But that one is not it's a soluble fiber. I know, Craig.
I just want to make one more comment, and we'll have the breakout session. But for people that don't go there, the thing we need to remember in this situation is the bacterial overgrowth in this situation isn't a traveler's type of bacterial overgrowth. It's typically caused by an abnormal anatomy, an abnormal motility, and other things like Kathy mentioned, reduced pH or increased pH of the stomach, so reduced acid. And so it's a lot different than what these products are created for. And as far as needing fiber, it's not necessarily true that we need a lot of fiber in short bowel, because the purpose of fiber primarily is to get energy down to the bacteria in the colon. And in the case of short bowel syndrome, you're getting carbohydrate down there whether you want it or not, typically, because you're malabsorbing it. So that's why the typical recommendations for bacterial overgrowth in the situation of short bowel syndrome or abnormal bowel anatomy is probably different than what you would hear otherwise.
Well, I think this just points out that this is an incredibly, oh, you want to say something?
Yeah,
Oh,
I have a child that we've been dealing with D-lactic acidosis. I had searched out Craig. I'm so glad you're talking about this because we had searched out Craig 3 years ago, I think, and it was before really anybody was talking about it. And I know there's a lot of us out here, but it's trial and error, and it's if you're doing well. But just we've been rotating antibiotics. We've tried so many different things, but the way we notice it, just kind of so everybody knows, best way to describe it, happy drunk. He's like, hey, I'm happy, I'm life of the party. Mean drunk, he starts getting really agitated and angry, and then he passes out. So if anybody has little ones, the way we found that, somebody described it to me that way, and we immediately got a blood test for D-lactic acid, acidosis, and we took it at our normal lab, and they sent it up to the Mayo Clinic.
well, I think that's a very helpful contribution. Kathleen, thank you so much. That's a tough
Can we take
topic.
more questions?
You want to, yes? Yep, one more. Yeah, have this one.
I just had one comment. My daughter had several taperings done, and that really was what made things better.
Just one thing, Kathy.
Yeah.
You didn't mention the ileocecal valve, and to individualize this to this audience, many of you have lost your ileocecal valve. And one of the things that the ileocecal valve does is prevent backflow from the colon, which is a literal cesspool, into the small intestine. And so when they connect the small intestine directly to the colon, you are a setup for bacterial overgrowth. And I have one really quick question, and that is when people pick up their prescriptions for antibiotics, the pharmacist will say, don't take it with any calcium. And my look at that for bacterial overgrowth is maybe the calcium will keep it in the small intestine instead of the blood. But does that alter the effectivity of the antibiotics in this case?
Well, you're keeping it, you're not going to be systemically absorbing it, as you
Right.
mentioned, because you're binding it. Depending on some of the antibiotics, it could, like, I guess ciprofloxacin would be the one we're thinking of most commonly, it's going to bind. You might see a reduced response, but again, we're dosing it lower than we'll use for treatment anyway. So again, this is where you have to be consistent on how you take your medication and have a conversation on how you feel. Because, I mean, that we can figure out. There are tricks.
I always tell people not to listen to the pharmacist who's telling you not to take the milk.
So you can see this is quite a battleground. All right.
But we still love our doctors.